Well, you'll be happy to know that since I gave you that rant in the first half hour, I feel better now, okay? I've relieved all that stress. And just understand, people who are very smart people, who have gone into medicine, who can discuss all these things, and their differential and integral calculus is perfect, when it comes to administrative things, are blatantly stupid. Just don't get me going on having to do, the 10 articles each year for renewing your boards in emergency medicine. Does anybody understand what that was all about? What it had was the ACGME just basically said, you've got to prove that people are keeping up. Well, how do we prove that? Have them send in money and do a test. So what it functionally did was quadruple the cost of being board certified in America. That's what it did, without any proof. What about showing, I'll compromise. Okay, we showed up every 10 years and took the damn test and went to Rick's course and did all that kind of stuff. That was fine. Again, something else which was picked up by idiots and said, well, this is good for you, right? Here, take this. It's good for you. Yeah? Prove that to me. Okay. Now we get to move on to a equally as depressing a topic, but at least it's scientific. That has to do with trauma imaging controversies and mistakes that we make. This is an obvious one. This is a no-brainer, but it goes on every day. All right, you're now working at Grayling, Michigan in the winter. And if you've ever seen winter, that's winter, okay? Or Peltston, Michigan. Peltston, Michigan and International Falls, Minnesota vie every day. Who has the coldest spot in the 48 states, right? And the snow is deep and it's ugly. Now there's a kid out on his snowmobile. He's been heading through a farmer's field. This is an actual case, by the way, because we run that emergency department. Going through a farmer's field. It's dusk. There's a barbed wire hanging at about that height. Did it do anything good to the kid? Well, I have two of these cases, one of which actually cut the guy's head off and threw it back and smashed the head of his girlfriend who was behind him. In any event, this kid's going, and now he's going into an emergency department in this little town. There's two nurses, there's the doc, and it's cold. What's the first thing we ought to do for this kid right now?
Call the priest.
That, I've often thought that we've sold in this country for years that this is the motion we should do. This is the motion we should do. But we didn't do that. But I think here's the question. In a lot of hospitals are really way stations for death. It's God's waiting room, right? They're a good place to die. They're a bad place to live. But make that decision early on. Because the worst thing you can do is be 3/4 of the way into a resuscitation and know you got to transfer them. Transfer them now. Once an airway is secure, in fact, just call. Just call now. If you hear they're coming in by the ambulance squad, get the helicopter coming, do something. Because if you can't really do it, don't pretend you can do it. And of course, all these hospitals now have what? They all have a CT scanner. The question is this, why? What are you going to find on the CT scan in that emergency department that you can fix? You never ask a question you don't want to know the answer to. I never ask my wife if she's cheating on me. Okay? Are we done now? She seems happy, the children seem happy. And at the end of this talk, you may get to see my daughter, who's coming to see me, but understand this. Decide what you want. Rule number one, we lie a lot. The only lie you can't tell is the one you tell to yourself. Oh, we can handle this. No, you can't. Shut up. Move. Number 2, the training programs actually are tremendously harmful in a lot of thought processes when it comes to this movement of patience. Have you ever called up and talked to some snot-nosed kid who says, well, you know, I'd like to send you X or Y? And you say, well, what's the hemoglobin? Who cares what the hemoglobin is? I take the orthopedic view. Who cares what the hemoglobin is? That's not right. When anybody out there thinks they need trouble, or they're in trouble, they need help, you know what? The patient does need help. Get the thing moved along here. So what are we going to look at? Oh, number 2, we have made some significant advances in dealing with the College of Surgeons in ATLS. You know, we weren't even invited initially to be a part of ATLS. You all know that, right? I got the worst jobs when I was president of this damn college. I had to go to the Bears Cave in Chicago. That's where the College of Surgeons is located, to meet with their head of trauma, our committee and their committee, to meet with their head of trauma about what we're doing wrong in trauma, as if they knew. Now, I'm not a guy with attitude. You know that. But their head of trauma, very arrogant son of a bitch, who started out the discussion by quoting Shakespeare. Now, you shouldn't do that in front of me, because my medicine's only passable. My Shakespeare is excellent. And I said, you know, the real problem here is you guys don't realize that 95% of the trauma in the United States is handled by emergency doctors first. Most hospitals in the United States, there's no surgeon sitting there. Fair statement? Yeah, you're doing it. Hello, wake up, you're not in charge anymore. And of course, he's got on his side, and we sat on each opposite sides of the table. You know, it looked like the, front line of the Chicago Bears over there, and all these professors of surgery. And I said, you just don't understand. You don't actually see it or do it. And you guys don't. Your residents might in the 400 training programs in the 400 hospitals that have X, Y, and Z. Not in most hospitals. He gets all upset about it and said, well, methinks the lady doth protest too much, as says in Macbeth. And I looked at him and said, the line, methinks the lady doth protest too much, is Act 3, Scene 2, line 252 of Hamlet. I hope your science is better than your Shakespeare. And now the fight was on. But if you read ATLS 1 and the recent modification of the ATLS manual, things have changed. Everything we sent them was right. Now, airway stuff, and you had 2 excellent talks by Diane on airway. Airway stuff hasn't come quite where it needs to be, but just remember that all this stuff that I was raised with, fingers and tubes in every orifice. Do you all remember that? Everything got a tube. The pizza delivery man got a tube if he slowed down. So you just had to be a little careful. All of that's gone now. And we are using selective things. But that was also the era of the pan scan. The pan scan. And this peaked, well, we don't know that it's quite peaked yet. But there's a great opening paper here, paper number 1, about what we do to humans when they come in from trauma. And this had to do with, this was published by Corley, JAMA 2010. What he looked at, and this is an easy study to do, brilliant but easy. He looked at the number of CTs we did on trauma patients between 1998 and 2007, 10 years. 10 full years. What happened in America? 300% increase in scans. 300%. Well, that means we should have picked up a lot more trauma, right? More diagnoses, more something real. And what he said is the increase in pickup may be 0.3%, 3 out of 1,000. And then you ask the question, was it something we had to get in there right away anyway? And the answer is no. Because sometimes we pick up subtle things that may be of importance at some point in time, but you know what? Obvious disease is obvious. You don't have to be very smart or much of a doctor. In fact, I don't even think you need a doctor for most of this. It's like the guy who comes in with ST segment elevation, 45 years of age and sweating. You don't need a doctor for that. That's handled by the PAs. They come in and say, here, there's the EKG, Dr. Henry. I said, do you have the cath lab on the phone? Yes, we do. Thank you. And here's the guy. Here's the cardiologist. It's that hard. So what are we finding with all this other stuff? Not much. Are we making them glow in the dark? Yes, we are. But it's more than just the radiation. And I don't want to concentrate on the radiation. We've already done that. What's the real problem in trauma in doing all these scans? Delay, delay, delay. And if you've got a scan in Moosonee, for all my Canadian friends, you know what? So what? Are you actually going to do anything about it when you find it? That's the question you should ask. Not do they have something, it's can we fix it? There is a whole series of discussions about what is actually necessary to transfer a patient. And I guess people said, well, you ought to have a C-spine film. No defense of that. Because what are you going to do if you saw something? Are you going to send them? Yes or no? Yes, you're going to send them. Keep them collared. Fine. What about an AP pelvis? Lots of bleeding from that. Never changed what you did. The only one that changed what you did, if we talk about plain films, is what? The chest x-ray. If you have a collapsed lung, you will do something about that. Even if you're in a Boy Scout tent, you can do something about that. But most of these other things you can't do anything about. Just be honest with it and get gone. In any event, I think that paper number 1 kind of lets us know where we went, and then it's forcing us to ask question, why are we doing this? And in certain locations, why are we doing it? By the way, America does not lead in stupid, crazy CAT scans. The Japanese are in love with the instrument. They're in love with the instrument. And they do actually more CT scans than we do per person in the United States. I'm sure the whole country must glow in the dark or something like that. Very strange. All right, question 2. Could we do a better job in imaging practices? And this is Article 2, which is a 2-star article, where he point out it would be very hard to do worse. This is how you know your system is crapped up, is when they get from your place to the next place, the trauma center, and they repeat the CT scans. Why? Why are they doing it? Now, when they actually looked at this problem, there were crazy answers. There were crazy, the film wasn't, our guys, our radiologists said, it wasn't perfect quality. What does that mean? Nothing. They want to bill for another damn film, right? Clinical correlation and another study required. And then they would say, well, they didn't send it, or it couldn't be decrypted, or it couldn't be this and that. This is 2014. If you can't send a disc or something over the airwaves, which is perfectly acceptable, there's something fundamentally wrong. What is the decrement in one of these digitalized images? Near 0. This isn't like we used to take copies of x-rays and things like that. It might not quite be good. No, this is none of that. This is a digitalized something. So what are we doing here? We have no idea. Here's the problem. We've got all of these damn transfers, and we don't have systems. When you think about it, You only send, how many people are here from smaller hospitals that send? You only send to 2 or 3 places, right? That's pretty much it. If you don't have it totally set up in advance, this is what IT geeks are for. They love this stuff. You're assigned to make sure that X gets to Y. If you're not doing that, there's something fundamentally wrong with the system. Number 3, repeat imaging here of CTs. And by the way, we make fun of the surgeons occasionally. They do publish a journal, which I think is, if you're going to read articles out of journals, I think that the Journal of Trauma is superbly edited. Excellent guys, well read. The Journal of Trauma is superbly done. I like their stuff. In any event, in May 12, this was from the University of North Carolina and Duke, which, by the way, are about 12 miles apart. All they said was, repeat CT scanning added nothing, no benefit, cost money, delayed getting to the operating room. I think that's a great statement. First thing, in most cases, don't do any CT scanning at small hospital A. Number 2, if you do CT scannings and you're at the receiving hospital, look at them first to make sure that they don't really need repeating. Because in most of these cases, it did not. And we're not the only ones involved in this. I have a lot of respect for a place in Canada called McMaster's, which is in Hamilton. Very progressive place. They looked at this exact same question. Because if you think we've got huge areas of nothing, look at the Canadians. They're mostly nothing. And then if you're within 100 miles of the U.S. border, that's where 90% of the population is. They have to send a long way. And basically what McMaster said is the exact same thing. There are delays. We're not getting it done. And it simply has to do with deciding to do CT scans at small hospitals that can't take care of the problem, and the repeating of scans. University of Colorado, another state that has concentrations of people and then nothing. They're even worse because they got mountains. And what they basically found out was at least a third of the repeat scans were due to some sort of problem in sending the image. I don't understand. Does anybody understand that? A third of them were due to problems in sending the image. Last time I checked, I just asked the lady in the x-ray department to give me a disc. The disc got put on the patient's chest along with everything else, and off they went. It was just that fast, a third of the time. Journal of Trauma, Article 6, 2008, misconceptions, misunderstandings. You do not need to document. This was an excuse when they went out and actually asked these people at small hospitals, why did you do that? You knew you were sending them. But here's the first question. Did you know they were going to go to the trauma center? Yes. Why'd you do it? They said to document the degree of injury. That's not requirement. That's not a requirement in payment anywhere. Emergency docs are paid for what they do, not what they find, right? See, if I was looking for an appendicitis, I don't get paid more money if it is an appendicitis. If I'm looking for a ruptured spleen, it's I examined them, I did this or that. You are not paid based on other reasons. So just think about that for a minute. You don't have to document things. Is it we wrong to put on the chart, major trauma looks bad? You ever had a transfer like that? In the old days, before there were a lot of emergency docs, I got the strangest damn phone calls you ever heard. I said, how are they? They say, too sick to examine. I don't know what I was going to do about that, but just understand not worthwhile. All right, let's take a look again at some of the other sort of major mistakes here. Article 10, again, Journal of Trauma. This is from Scripps in La Jolla. Not a rural area. You know, if you want to see high-priced homes, try La Jolla. This also had to do, this one had to do, we're switching gears now, with warfarin and aspirin and observation, again, trauma patients, but they got something on board. What actually happened in those patients? By the way, I've got another series of papers about people with trauma and Coumadin on board. This, however, I think is great. They looked at 6 hours of observation following a scan. 6 hours of observation. Are they going to bleed? Is there something going on? CT scan changed, and they re-CT. I don't know how they get this through the Human Use Committee. They said, well, you're looking okay, but we're going to scan you again. Would you let your family get in that state? I don't know why they did that. Anyway, 6 hours of observation, re-scanning. And these are people whose Coumadin use was all over the map, or aspirin use, whatever, all over the map. Less than 1%. Less than 1%. What does that mean? That means you don't have to rescan people. Normal is normal. Repeat exam is a repeat exam. Why they actually decided to spend money, shoot rads, do this, what they said is, doesn't work. So no matter what these people are, no matter what they've got, it's hard to beat normal. I think particularly in trauma. And because they've got some other medication on board, don't jump in on this. Question 4, what about the initial bleed or rebleed rate? Is it worse with warfarin or clopidogrel? You and I have been taught that clopidogrel is sort of a innocuous drug, right? Not a big problem, not as bad. Totally wrong. It's a drug which is still in search of a disease. We don't know what to give it for. Because if you really want to anticoagulate somebody, is that what you want to give? No, it's an antiplatelet drug. It doesn't work well. Does it have bleeding side effects at exactly the same level as warfarin? So anybody who thinks it's a little safer, it's this or that, no, it isn't. And when you actually look at people, let's take the groups that we're giving this to at this moment in time. Let's say they've had a TIA, posterior fossa TIA. Somebody said, well, here, go home, take an aspirin. Well, what if you said to them, and if you talked to the company, they'd say, oh no, let's do a much better antiplatelet job and give them clopidogrel. What's the difference in the best of studies between those two groups as to who's going to have another TIA? Less than 1%. It's interesting that aspirin plus clopidogrel may give you a 1% or 2% advantage, depending on whose study you look at. Just understand the problems you buy with GI bleeding, with all this other kind of stuff, I just don't think it's worth it. I think it's very difficult at this moment in time with the current papers to defend clopidogrel as a medication. Now, I know the company's not going to agree with that. They think it's good. Is it expensive? Yeah, it's relatively expensive. How much does an aspirin cost? You can buy $5, you can buy a barrel full of it down at Costco, something like that. That's about what the cost is, $5. And yet the bleed rate is significant. It's equal to that of having the patient on warfarin. So when you're advising patients what to expect, who's going to have problems, they should get the same warnings as the warfarin patients get. And I think we don't think about that enough at all. it is not my favorite medication. All right. The effects of clopidogrel on the elderly trauma brain. Again, Journal of Trauma, 2008, Article 13. What they basically said was there is a small risk, and I hate when they use this term, in those over 65. I'm now in this decrepit group of people. There's nothing I can do about it. Is there a small risk? The answer is yes, there is. So, again, it's not totally safe. It's like when we talk about, aspirin and clopidogrel should not be spoken of in the same group as danger. You cannot speak of it in the same group. The American Journal of Surgery had essentially the same view of this, Article 14, but we tend to suppress this all the time. And let me see. One other point I would make, and then we're done. In Article 15, the incidence and prediction of intracranial hemorrhage after minor head trauma. Again, you've got to define what minor head trauma is, taking any medications. I think this number is relatively bizarre. If you look at all the studies, remember we've been talking about 1 and 2% danger rates, bleeding into the head, or less. I don't know where these people came from. We included this paper just because, because you got to throw out some of the stuff that's looking tough, but how you can relate this number with all the other things we've talked about, I have no idea. They actually said in 141 patients, 29% got an intracranial hemorrhage in minor head trauma. Do any of you have that personal experience? I've never seen that in my entire life. I don't know where these people are from. They've got to be crazy folks, or how they've decided. Maybe minor head trauma to them is like only a 5-pound hammer and not a 9-pound hammer or something like that, because this is strange stuff. Take 15 and understand this is the radical end of the spectrum. Nobody reproduces that number. When you think about bleeding, it's the 1% kind of number, and clopidogrel is just as dangerous as warfarin. It is not a safer medication.